I'll be presenting about diabetic foot abnormalities and their management plus the wound care. So basically, diabetic foot ulcers are the start of a cascade of events that contribute to repeated infections, hospitalizations, surgeries, and as well as amputations. These, in fact, contribute to about 10 to 50% of some kind of amputations. And manifestations in the foot exemplifies the systemic disease process with the development of peripheral sensory neuropathy, motor neuropathy, autonomic neuropathy, limited joint mobility, as well as Charcot arthropathy. Diabetic foot ulcers usually develop at the site of pressure areas that are exposed to repetitive injury or at a constant pressure at bony prominences. Neuropathy eliminates the perception of pain and unrecognized injuries until infection damages enough tissue to cause pain. Macro and microangiopathy impedes the response to both infection and normal reparative processes. This is a picture depicting of a triad of peripheral neuropathy, pathobiomechanics, and peripheral vascular diseases that leads to an ulcer development in case of a diabetic patient. Coming to peripheral neuropathy, the peripheral neuropathy is a progressive pathological process that develops in the environment of diabetes, prolonged poor glucose control, and microvascular disease. Glycation-induced metabolic and vascular changes of the nerve fibers results in sensory, autonomic, as well as motor neuropathy in the lower extremities. Patients often present with combination of small as well as large fiber neuropathy. Small fiber neuropathy patients complains of symptoms of basically burning, tingling, and radiating electrical pain, and these are usually treated by off-label drugs. Patients coming with small fiber neuropathy basically have the inability to perceive temperature differences. In case of large fiber neuropathy, patient complains of numbness, tingling, and formication. These are tested in the clinic by using a 128 Hertz tuning fork or a 10 gauge monofilament or an Achilles strip tendon reflexes. Large fiber sensory neuropathy is often so severe that patients lack sufficient peripheral sensation to protect their feet from injury. And this term is referred to as loss of protection sensation. And for peripheral neuropathy, two main FDA drugs that have been approved are the pregabalin and duloxetine. Autonomic peripheral neuropathy is related to the increase in the sympathetic tone in the diabetic lower extremities. Dysregulation can lead to arteriovenous shunting, small vessel ischemia, and changes in the soft tissue turgor. There's also xerosis as well as loss of elasticity. This causes fissures and tears. This combined with chronic edema causes increasing in the susceptibility of the minor tissue injury and ulceration. Motor neuropathy leads to muscle atrophy and imbalance of the opposing muscle groups. This is more apparent in the smaller intrinsic muscles of the hands and the feet. With severe motor neuropathy, patient hands can develop a monkey paw or an intrinsic minus foot at the atrophy of the intrinsic muscles. In the foot, the motor neuropathy contributes to the development of forefoot deformities such as hammer toe and hallucis abductor valgus, which are reported to be the major contributors of ulceration, nearly around 90 to 70%. And surgical decompression of the peroneal and tibial nerves have a major role if the disease is not too advanced. The peripheral arterial diseases, perfusion is arguably the most critical element in diabetic foot ulcer healing, amputation level selection, and limb salvage. Tools to measure functional perfusion, traditionally you can use arterial Dopplers or the new technology such as the hyperspectral imaging and the SPY fluorescence imaging system. Angiosomes targeted revascularization enhance wound healing. With infection, surgical excision of the infection needs to be achieved before revascularization. But in case of an ischemic ulcer, debridement should be done after revascularization until and unless there's an underlying infection. Uh, the classification system, there's a combined Texas and Wegener's classification. It's a 4x4 matrix where Wegener's classification and Texas classification are both combined, and which also where infection ischemia is involved. Coming to biomechanics, structural changes occur in the diabetic foot that alter the underlying biomechanics. The stiffening of soft tissue structures, including tendons, ligaments, and joint capsules, uh, causes shortening of the tendon and loss of their elasticity, uh, which later leads to hamartose or equinus deformity, leading to complementary gait changes. Offloading these are the devices used to protect the foot and reduce the pressure and shear, and is an important aspect in when you're dealing with the healing of diabetic foot ulcers. Basic concept is that the offloading focal areas of pressure and distributing it across a wider surface area, changing gait patterns, and reducing the number of steps taken during the course of treatment. Uh, Basically, there are multiple types. These are the padding, orthotrotics, braces, over-the-counter fracture boards, and total contact casts. The picture on the left-hand side is the total contact cast. These are the most effective offloading techniques to heal the plantar ulcerations. With total contact cast, about 70 to 90% of the patients heal in an average of approximately 42 days. One of the reasons that total contact cast may be effective is that because they're forced to compliance with that exist with the cast. And whereas the other modalities are including you have the walker boots, healing sandals, and insoles. Surgical corrections is main goal is to optimize the function while minimizing new ulcer formation or ulcer recurrence. Surgical correction can be conducted to heal an ulceration that are not healed with traditional approaches or when ulcer recurs despite using standard prevention approaches. Various techniques are the Achilles tendon lengthening, the digital flexor tendon releases, exostosis, exostomosis, and tendon balancing, and skeletal reconstruction such as the TL and midfoot arthrodesis. Basic four fundamentals of wound healing are ensuring or establishing adequate perfusion, providing optimal offloading, controlling or treating acute infection and biofilm formation, optimizing the patient's metabolic and nutritional status. Coming to Charcot neuroarthropathy, this is nothing but an end-stage sequelae of pathological diabetic foot process that has devastating clinical and economic consequences. About 5.5 to 8% of the patients with diabetes develop Charcot neuroarthropathy. An acute traumatic event or the cumulative effect of minor trauma can incite a Charcot neuroarthropathy episode. It has four stages. Stage 0 is a clinical stage presenting with warm, swollen, with often painful foot. Stage 1 is fragmentation or destruction of bony casts and erosions. Stage 2, which involves the joints, that is the joint subluxations. Stage 3, there's an arch collapse. And stage 4 is consolidation. Treatment is basically early recognition and immobilization with non-weight bearing. Coming to an impaired host, basically diabetic patients are of less of immunity and are more susceptible to infections. Patients with diabetes have 4 times the hospital admission rate and 5 times the complication rates compared to a patient without diabetes. These patients, basically the clinical signs of infection such as the rubor, calor, dolo, and tumor are absent or diminished. And the mechanism for high rate of wound chronicity and an infection. Hyperglycemia is associated with leukocyte dysfunction, which leads to neutrophil demonstrates delayed chemostasis, poor phagocytosis and adhesions, and impaired myeloperoxidase function. And also, microbes can escape the innate immunity and causes acute infection. Coming to infections, portal for infection in the diabetic foot is typically an ulcer or infection seeded through a puncture wound. Diabetic foot infections are typically bacterial and can be monomicrobial or polymicrobial. The most common bacterial pathogens are the Staphylococcus as well as the Streptococcus. Combined foot infection severity classification from the Infection Disease Society of America and the International Working Group on the Diabetic Foot gives a glimpse of the classification, where it is basically classified into mild soft tissue infection, moderate, severe, moderate bone infection, and severe bone infection. Treatment of acute infection usually requires a parenteral antibiotic, surgery for decompression, excision of infection, and amputation. Empiric antibiotic coverage is broad, and then the therapy is targeted based on the culture and sensitivities from deep tissue and bones. Coming to wound care, the most common etiological factor in non-healing ulcers are chronic venous insufficiency, arterial occlusive diseases, and diabetic neuropathy. Patients with arterial insufficiency and diabetic neuropathy are at the highest risk of limb loss. Normal wound healing, healing of an acute wound uh, goes through a well-defined phases of hemostasis, inflammation, proliferation, and remodeling. In case of an first coming to inflammatory phase, this is mainly mediated by the mast cells, neutrophils, macrophages, as well as the inflammation. This occurs within 24 hours of acute injury to up to 2 weeks. In this phase, these involved cells produce chemokines, cytokines, and growth factors, and which in turn release the tumor necrosing factor alpha, interferon gamma, and interleukins. The neutrophils release concentrated MMPs. These are nothing but matrix metalloproteinases. The MMPs are responsible for the clearing of damaged tissue from the wound area by breaking down collagen. This is done by MMP1 and MMP8, as well as gelatin done by MMP2 and MMP9, and elastin. The activity of MMPs are regulated by the tissue inhibitors of MMPs, which are secreted by the macrophages. Coming to proliferative phase, in this phase, there is release of platelet-derived growth factors, tumor growth factor beta, and vascular endothelial growth factors by multiple cells, but primarily by the macrophages. In this phase, there is recruitment of fibroblasts and initiation of angiogenesis. Coming to remodeling, this is a process in which type 3 collagen is largely replaced by type 1 collagen. Now, in case of an abnormal wound healing, chronic non-healing wound occurs when the normal healing process is disrupted, and as a result of underlying disorders that causes a prolonged, unchecked pro-inflammatory state. These basically include venous hypertension, chronic pressure, bacterial colonization, inadequate tissue perfusion, and cellular senescence. In inflammation, there's persistent upregulation of pro-inflammatory cytokines and MMPs. The chronic wound fluid may contain high levels of MMP2s and MMP9s, MMP9, and abnormal levels of low levels of TIMPs. The wound fluid inhibit the DNA synthesis of mitotic activity of normal skin fibroblasts and keratinocytes. Chronic wound fluid may contain high levels of MMP and MMP2 and MMP9, and abnormal low levels of TIMPs. In cytokines, there is upregulation of pro-inflammatory cytokines, including tumor necrosis factor, interleukin 1 and interleukin 6. In cell synthesis, these are noted in fibroblasts commonly noted in fibroblasts that are collected in non-healing ulcers. Stimulation of senescent fibroblasts may be a key target of therapy for improving the healing potential of chronic leg ulcers. The basic etiology, like I said, is venous leg ulcers, diabetic foot ulcers, and ulcers associated with arterial insufficiencies. Various differential diagnosis of chronic non-healing ulcers. You have the infectious conditions such as mycobacterial, fungal, bacterial, malignancies such as basal cell carcinomas, squamous cell carcinoma, macrovascular arterial insufficiency, atherosclerosis, embolic events, vasculitis such as diabetic microangiopathy, thromboangiitis, obliterans, Raynaud's disorders, venous insufficiencies, deep venous thrombosis, lymphatic obstructions or lymphedema, hematological abnormalities such as anemia and polycythemia, collagen vascular disorders such as SLE and scleroderma, and excessive pressure such as seen in cases of decubitus ulcers or diabetic neuroarthropathy. Coming to venous leg ulcers, there is persistent venous hypertension and chronic limb edema leads to the gradual development of skin changes. Chronic upregulation of pro-inflammatory cytokines appears to mediate the development of tissue fibrosis and clinically appearance of lipodermatosclerosis. Ulceration eventually occurs either spontaneously or due to chronic limb injury. Coming to diabetic foot ulcer, there is underlying causes of ulcer must be addressed before specific wound treatment can assist in healing. Inadequate pressure offloading is the most common cause of failure to heal. Uh, Limb ulcers associated with arterial insufficiency. Chronic limb ischemia has been identified as a major risk of amputation in 25 to 40% patients at 1 year if revascularization is not performed. Revascularization should be considered early in those with more severe wound grades and those with pedal gangrene. Wounds treated initially with wound management without revascularization should be monitored closely for a progress, and if that does not occur within 4 to 6 weeks, revascularization should be considered. Toe pressure of about 20 to 50 mmHg, 85% of the patients were able to achieve limb salvage with wound management, compared with only 60% in those with toe pressure less than 20. And with pressures less than 80 mm or 10 mmHg, in whom only 8% of the patients achieved amputation-free survival at 3 years. Various other causes of limb ulcerations are, like I said, vasculitis, sickle cell anemia, malignancies, and other dermatological conditions. The various wound classification systems that is already been explained are the Wigner and Texas classification, combined Wigner and Texas classification, and the Wi-Fi classification. Um, the Wi-Fi classification is more pronouncedly used, and one addition to add-ons to Wi-Fi classification is the ambulatory functions that assist in decision making. Coming to wound size management, routine wound measurements allows the consideration of alternative treatment methods as soon as progression in wound healing ceases. Various methods available include the digital photography with computerized planimetry, direct planimetry, and simple measurements of dimensions. Coming to wound bed preparation, basically this includes debridement of non-viable tissues, identification and correction of bacterial involvement, control of chronic inflammation, elimination of limb edema, and control of wound exudate. Coming to debridement, debridement is required to excise non-viable tissue and should be aggressive, particularly at the initial evaluation. More frequent wound debridement achieve better healing rates. However, the current body of evidence provides no definitive guidance on the question of how often chronic wounds should be debrided or the best timing. Alternatives to surgical debridement includes chemical debridement, ultrasound debridement, hydro debridement, and larval therapy. Basically, in summary, you can say that no other form of debridement has demonstrated superiority to standard surgical debridement. Alternative methods are basically recommended only when surgical debridement is not possible or is not desirable. Bacterial colonization, wound infection requiring systemic antibiotics is seen in about 20 to 25% of the cases. Biofilms harboring bacteria secrete a polysaccharide substance that cover colonies which grow and interact and inhibit the host generated control mechanisms. In chronic wound, biofilms appear to multiply at a point to which they inhibit the healing by stimulating chronic inflammation, inactivating growth factors critical to the healing process, and preventing orderly angiogenesis requiring further healing. Several factors influence the effect of bacteria on the wound healing. These include the bacterial load, bacterial species, virulence, and the biofilm. Wound healing generally begins to decrease at 104 colony forming units per gram of tissue. Coming to dressing, various types of dressings that can be done for diabetic foot is alginates, collagens, composites, foams, gauze, hydrocolloids, hydrogels, and superabsorbents. Diabetic foot ulcers are typically treated with dressings that donate moisture to the wound bed, such as the hydrogels, because the wounds usually produce little exudative drainage. More heavily draining wounds are better treated with alginates or hydrofibers. with greater moisture removal capabilities. Whereas the venous leg ulcers are highly exudative and a high protease content in the fluid, in their fluid, with these require more absorbing dressings that actively wick exudate away from the wound and the surrounding skin. Uh, Coming to venous leg ulcers, it basically treated by using compression. Sustained high strength compression of the limb remains one of the basis of treatment for venous leg ulcers. Pharmacologically, it is also we can also use fentoxyphylline flavonoids. Flavonoids are nothing but plant-derived compounds which contains anti-inflammatory and antioxidant properties. Flavonoids, in addition to compression, have a significant benefit in treatment. Anticoagulants, basically low molecular weight apparent. These are not routinely used. These can be considered only in selected, carefully selected recalcitrant ulcers that are not responding to any other treatment. Whereas adjuvant therapies to accelerate wound healing are nothing but skin grafting, growth factors, living human skin, equivalents, collagen matrices, platelets, topical therapies, ultrasound, and electrical stimulation. And also there's patient also benefit from progressive resistant exercises, at least 30 minutes of walking at least 3 times per week. Diabetic foot ulcers, which was previously mentioned, they also benefit from vitamin D as well as growth factors. Um, till now, only growth factor that has been FDA approved was the platelet-derived growth factor, that is the bicarpillin. It is a recombinant human form of isoform of platelet-derived growth factor. But there was a in 2008 there was an FDA warning of black box warning causing a fatal cancer. But there was no increased risk of malignancy in patients treated with bicarpillin. But those who developed malignancy had a greater risk of dying from them. Coming to intermittent pneumatic compression, basically there are two types of intermittent pneumatic compression. One is a synchronized and the other one is a non-synchronized one. In case of a synchronized one, in case of synchronized intermittent pneumatic compression, uh, the compression and deflation are gated to the cardiac cycle with around 55 to 80 mmHg applied at the end diastole to maximize the venous emptying. Pump decompression occurs before the systole to reduce the afterload and limit compression-related competition with systole inflow to the limb. Non-synchronized IPC in this typical protocols involves an inflation pressure of 120 to 180 mmHg and inflation duration of 3 to 5 seconds and a deflation time of 15 to 20 seconds. IPC of the affected limbs are recommended for 2 to 4 hours daily. Non-synchronized IPC is generally less expensive and is more amenable to home use. This makes it attractive. This makes it attractive given the length of the therapy required in patients with CLI. IPC reduces the edema that often occurs in patients with CLI. This combined with the improved venous emptying during the IPC may result in an increase in the arterial venous pressure gradient in the limb. With less resistance to inflow, blood flow may increase, resulting in increased tissue perfusion, relief of fresh pain, improved ulcer healing. IPC also has been reported to increase the concentration of prostacyclin and nitric oxide in the treated limb. Coming to negative pressure wound therapy, this was introduced in 1997 by Argenta and Morkivas. This basically refers to any device which seals the wound, creating an airtight atmospheric over a vacuum, and a vacuum can be applied. Basically, it works on two main principles. Primary is you have the macro deformation, which causes the wound shrinkage and draws the edges together. And next, you have the micro deformation, where it strains on the surface of the wound, affects the cytoskeleton, and enhances the granulation. And it also removes the fluid removal, and there's an alteration in the wound environment. In secondary, it causes neurogenesis, angiogenesis, cell proliferation, and differentiation and migration, and also causes granulation tissue formation. Clinically, it uses a promotion of wound area reduction, granulation, like I said, and the clearance of infection in diabetic foot ulcers. It can be combined using a silver, which causes an increase in the antimicrobial potency, platelet-rich plasma, as well as with installation of NS or a sodium hypochlorite. Main contraindications are osteomyelitis, unexplored fistulas, exposed vasculature, anastomosis of nerves or organs, bleeding, diathesis, malignancy, and necrotic tissues. Major complications are infection, sepsis, foam retention, bleeding, and pain. Coming to hyperbaric oxygen therapy, hyperbaric oxygen is a treatment in which patient breathes 100% oxygen intermittently while inside a treatment chamber at a pressure higher than at sea level pressure. Basically, there are two types. One is a monoplace, or second one is a multiplace chamber. In a monoplace chamber, a single patient is accommodated. The entire chamber is pressurized with 100% oxygen, and patient breathes the ambient oxygen or ambient chamber oxygen directly. In case of a multi-place chamber, holds two or more people and is pressurized with compressed air, while patient breathes 100% oxygen via masks, head roads, or endotracheal tubes. Basic mechanism of action is primary. Coming to primary effect, increased pressure and hyperoxia with partial pressure of oxygen 200 mmHg at 1 atmospheric pressure can increase to about 20,000 millimeters of Hg at 3 atmospheric pressure. Secondary effects are basically controlled oxidative stress, ROS, and reactive nitrogen species involved in the pathways of wound healing. This leads to an increase in the local growth factors, which heals in wound healing. Hyperbaric oxygen chamber is reportedly useful in the treatment of number of wound problems, including complex diabetic foot ulcers, osteomyelitis, necrotizing fasciitis, and healing of a tissue flaps. Typical treatment protocol for leg ulcers involve 1 or 2 treatments daily for a total of 20 to 40 treatments. The major complications involved in hyperbaric oxygen chamber are middle ear barotraumas, pulmonary barotraumas, CNS toxicities, leading to oxygen toxicity seizures, sinus or paranasal barotraumas. Thank you.